Hi, so my name is Maximilian Merz from Roswell Park Comprehensive Cancer Center. And at this year's ASH, we presented data on spatiotemporal assessment of immunogenomic heterogeneity in multiple myeloma. And for a long time, we always ask ourselves why plasma cells, myeloma cells, cause osteolytic lesion in one region of the body, while other regions, like the pelvic bone, where you usually perform your bone marrow biopsy, show no signs of osteolytic lesions, although you can have 90 or up to 100% plasma cells in these regions. So we always wondered if the plasma cells are somehow different, like the metastases of a solid tumor. And because of that, we set up a clinical trial, a prospective clinical trial, where patients were offered a regular bone marrow biopsy under CT guidance, and then in the same session, an imaging-guided biopsy of an osteolytic lesion. So we discussed with our radiologists always the possibility of if a patient, a newly diagnosed patient or relapsed patient, has a new osteolytic lesion that lights up on PET, and if this is accessible for CT biopsy. And it's a prospective trial. We are allowed to enroll 50 patients at Roswell Park at the moment, and we presented first data from the first 18 patients. And a couple of things were pretty interesting what we found out. So first of all, when we looked at the whole exome sequencing data from plasma cells from the bone marrow and the osteolytic lesion, we did not find too many differences. So especially in newly diagnosed patients, the mutational profiles were very much comparable between the osteolytic lesion and the bone marrow. But that was not so true anymore if you looked at relapsed patients and especially patients with extramedullary disease. So in general, the mutational burden was higher in these patients with relapse disease and extramedullary disease. And also the differences between bone marrow plasma cells and osteolytic lesion or extramedullary lesions